All right, so I'm going to talk about three things today. One, I'll talk about a model for understanding low vaccine uptake. Then I'll talk about the situation with HPV vaccine coverage in the United States, and then I'll close off with some of the activities of the National HPV Vaccination Roundtable that's in the United States. So I should acknowledge some potential conflicts of interest. I have funding from federal sources, government sources, non-government sources, as well as industry. So a few years ago, colleagues and I developed what we call the increasing vaccination model. I'm going to share it with you briefly. The reason for that is because it's become quite well adopted globally. It has guided the CDC in their current work on understanding confidence and hesitancy around COVID-19 vaccination, as well as other kinds of vaccines. It's been adopted by the World Health Organization in some similar work, including this report here, identifying ways of understanding COVID-19 vaccine uptake. It's also being used by several industry partners, and then of course a bunch of NGOs and some nonprofits. So this model proposes there are three different things that we should be thinking about when we're considering vaccination. One is a bucket of things called what people think and feel. Their risk appraisals, their confidence, their motivation, their hesitancy. There are also social processes, which is to say social norms, their social networks, and possibly altruism. Then finally, there's direct behavior change, which includes efforts to build on motivation or to shape behavior, but none of those try to change the social world that people live in or what they think and feel. Now, I want to go through the evidence for each of these different buckets and the propositions. So this idea that changing what people think and feel will change behavior is not really well supported. So messages that increase disease risk appraisal have a likely impact of really nothing. We have a really nice systematic review and meta-analysis by Parsons that shows, of 16 studies, that shows no effect of this kind of an effort. Now, some of these others have some effect. So certainly educational campaigns that increase vaccine confidence might have some effect, but it's really quite unreliable. Motivational interviewing is something where there's a really nice and growing body of evidence that it could be effective, but in terms of strict RCTs, we don't yet have them. So when you look at social processes, it's a slightly different story. Descriptive norm messages are probably going to work. We have lots of evidence in other areas, so it'd be surprising that it doesn't work here, and it should be at least modestly effective. Social network interventions that build on contagion, the idea of the spread of information across the social network is also very promising. Messages that change altruism or free-riding beliefs are not likely to be all that hugely effective. Now, contrast all of that with the direct behavior change world, where presumptive healthcare provider recommendations are very effective according to several RCTs. Reminder recalls are actually really effective too, one of our best effects, but clinics tend not to implement this intervention, so we knocked it down a little bit. The next two are relatively small effects, but still detectable reliably. On-site vaccination, we've heard that the idea of vaccination schools in the UK from the last presenter, and in the US we don't have that. We typically are doing clinic-based vaccination, but moving it to people's workplaces or their place of school locations, those are quite effective, and so on. So this bucket of stuff is a really effective and reliably effective way to increase vaccination. I always like to make this caveat here that what people think and feel is very likely necessary. High confidence in a program or policy is and vaccination is very likely necessary in order to be able to implement all of the direct behavior change techniques that are truly effective. Another caveat that I'll make is that most of the data that we have on what works is from high-income countries. So for work in low and middle-income countries, it's likely that these things would work, but we just don't know that much about it. So let me now turn to what's most relevant here, which is the US pandemic and HPV vaccination. So when the pandemic hit, we basically canceled or delayed well child visits. So as I said, almost all of our medical care happens in the context of clinics, or possibly, meaning you go to see a private provider, or possibly a public clinic. There's a small number of schools that have some form of school-located vaccination. 6% of them have on-site clinics. So then there was the development and rollout of new clinic safety protocols with this safer at home framework, and then primarily virtual work and school, very few people in person. It's only really recently that we've started getting back to school. So one of the consequences of this, all of these changes, was a steep drop in various childhood vaccines, the uptake of these vaccines. So for MMR and DTaP, so DTaP is diphtheria, tetanus, and pertussis, and that is given to younger children. Tdap would be the one that's given to older children in the US. So you can see a drop, but HPV is the one that really stands out. It had a 75% drop at one point, and that's a relative drop. So we were not quite stopping, but we had, at that point, we were giving very little HPV vaccine, and that was a big concern in the United States. So here are some data from the CDC, and what this shows is the period. If you can take a look on the left-hand side, you see the yellow circles that are pointing out where key moments in the pandemic were, and then you can see toward the middle, the gray bars were a previous period, and the green bars are the pandemic period, and the green bars show quite a bit lower HPV vaccine orders. This is through the Vaccines for Children program. So about half of our doses in the US are provided for free through the Vaccines for Children program, and the other half are provided through public sources. So the consequence is that although we've mostly caught back up with routine administration in the United States, we have a large deficit, and that deficit is something we're going to have to try to figure out. We also have, on average, and we're down for the year 21% in HPV vaccination, 20% for Tdap, that's the one that's given to adolescents, and then 16% for this meningococcal vaccine. So what that means is that we're down, HPV vaccination is down by a documented at least 1 million doses through the free program, and then the other half in the private program we don't have as much visibility into, so it could be up to 2 million. So we're down 1 or 2 million doses, and that's a really huge deficit. It does appear that our public program is more effective than the private program. So what can we do to get HPV vaccination back on track? So early on, I saw some of these things happening, and I, as the founding chair of the National HPV Vaccination Roundtable, I asked the roundtable to convene a regular meeting, a monthly meeting of the leaders in HPV vaccination in the U.S. And so that's the CDC, it's the American Academy of Pediatrics, American Academy of Family Physicians, industry partners, and so on. So there's a little bit of a who's who, a small group that meets, maybe about 10 of us, 10 to 20 of us, depending on the topic and the month. So we also took the apparatus of the National HPV Vaccination Roundtable and turned it toward the task of trying to get back on track, creating resources, materials, meetings, and so on. So one of the things that we did is we started these, as I mentioned, these stakeholder calls that gathered national organizations for ongoing information sharing. And we shared public and private sector data. They gave updates on their organizational strategies and activities. And it created this really nice open communication flow. And one of the most interesting things was some of these organizations at a very high level sharing different takes on what was going on in the world. Some were concerned, some were not. Some had conflicting data. And so what happened over a period of maybe 4 months is this topic rose to become an urgent priority for each of these organizations. They also came to understand the different ways of looking at their data and coming to a general consensus that we had a national crisis on our hands. So the general approach of the roundtable is to convene, communicate, and to catalyze. So as I mentioned, we can convene these external groups. We also published a document on promising practices for adolescent vaccination during COVID-19 with specific suggestions for intervention. We also had a commentary in the Journal of Adolescent Health. We created a video playlist, separate ones for health systems and for parents. We maintain a channel on YouTube, and we of course have included the HPV board's outstanding videos from a recent meeting. We can add more if you'd like. We were also quite active on social media with parent-facing materials that incorporated themes identified through parent and provider focus groups, as well as stakeholder input. We created messaging documents, and those messaging documents include fact sheets on the current situation with content for social and social media newsletters. There was a letter template for providers and parents, and then we also had resources for health plans and health systems. So health systems for us are large accumulations of clinics. Often there'll be a hospital system with 10 or 20 or even 100 clinics. A health plan is an insurance company or some other kind of organization that helps to potentially provide medical care, but typically it's about insuring folks. We created a bunch of infographics to help people understand what was going on. And so we had an at-a-glance overview of the urgency, some statistics, the COVID-19 implications, and then a call to action for health systems and health plans, as well as sharing with them the Healthy People 2030 targets. Those are the targets for the nation. We had a call to action for health systems. These are the large integrated clinic systems in the United States. And we had a large national meeting for that. More recently, we've started to work with payers. Those are the health plans. And so we had this webinar just in March, a safe return to in-person schooling, an urgent call to action for health plans to close the adolescent vaccination care gap. We had 600 attendees at that, and these are 600 pretty important folks. So we were very proud of that meeting and some of the action that's resulted from it. We maintain a resource library that has all of the things that I described to you, including the videos and so on, and that's available. They're all available online. We're also happy to consult with local governments if it's helpful. So one of the characteristics in the United States of HPV vaccination and other adolescent vaccines is a summer vaccination peak. There's about 60 to 70% of our HPV vaccine all happens during just a couple of months in the summer. That's a consequence, a side effect of school entry requirements for Tdap vaccine and to some extent meningitis vaccine. So HPV vaccine gets brought along, but it also means that anything that happens in the summer, it has a particular residence. So the introduction of Gardasil 9 was a bit challenging in some ways. The COVID pandemic has just been devastating, as you saw, to the summer vaccination efforts. So looking forward, we have a new problem to consider. And that new problem is that in the United States right now, the licensure of a COVID-19 vaccine is for adolescents ages 12 to 15 is pending and will likely come soon. One consequence or one sort of problem is that there's a period of time when you cannot provide other vaccines, 2 weeks before the COVID-19 vaccine and 2 weeks after. And so that could possibly destroy our summer uptake drives, and that's a big concern for us right now. So yes, this EUA, the Emergency Use Agreement application was submitted by Pfizer recently in the last couple days. All right, so we created a call to action to prioritize adolescent immunization now to catch up on missed vaccination doses. That's that 1 to 2 million missing. And then to try to move the usual back to school vaccination efforts forward to March to May 2021. I don't know if that's going to be successful, but it's one of the few things that we have as a resource. We've tried to activate health plans, health systems, providers, and parents. And then we've tried to encourage people to access and use these tools and resources that I've described. So in conclusion, the increasing vaccination model offers insights for programs and policies. It's been particularly useful for helping to understand how to assess confidence, hesitancy, and so on. There are efforts by the World Health Organization as well as the US CDC that use this model and quite a few other organizations as well. COVID-19, the pandemic wiped out recent HPV vaccination gains and threatens recovery. So we're probably mostly back on track for rates as long as something newly dramatic and awful doesn't happen. However, we still have this 1 to 2 million doses that are a shortfall, and that's a huge problem for the US. And then finally, we need national efforts. That this is an ongoing and fluid situation, and we're trying to get all partners involved. Thank you very much.